Well, Doctor, I met you at ASH, and I saw your presentation, and I was in a room with a lot of people, and I got to say that I was truly impressed, and that's why I wanted to have you on this program. If you could you please provide our audience with your thoughts on early treatment of myeloma and why you believe this is so important for the future of myeloma treatment, and do it in a way that is a little patient friendly, because I can tell you that you are so intelligent and so skilled in your field that my brain almost exploded listening to you.
Sure, I'm happy to do that. So the whole question came along when we see patients with precursor conditions, which is MGUS and smoldering myeloma. And we all usually tell them, oh, don't worry, you don't have symptoms yet, we should do watch and wait. And when you have symptoms, when you have lesions in your bones, when you have anemia, when your kidneys are failing, then we will start treatment. But if you think about what we just said right now, it doesn't make sense to anyone. And actually, a lot of our patients will say, well, why are you waiting? What are you waiting for? And many of my patients will say, is this watch and worry and not watch and wait? And if you think about the whole, if you think about what we do in other cancers, for example, take breast cancer. You see a patient with an early breast cancer lesion, a small lesion that has not done anything more. We call it DCIS, or ductal carcinoma in situ. The patient would have a mammogram, would see that tiny lesion. We immediately remove the lesion. We say, absolutely, let's remove it. We never say, oh, you're having no symptoms. Let's watch and wait until you have lesions in your bones, until you have metastasis everywhere, and then I will treat you. That would make no sense at all for anyone. Yet we do it every single day for our patients with myeloma. In fact, some people, are so happy to say, oh, I'm doing the observation, I'm doing the watch and wait, and letting all patients have all those problems at the end. So you ask me a question that maybe why we're not curing myeloma is because we're not treating it at the right time. Maybe we're waiting too long and it's too late for us to treat our patients. And maybe we need to rethink the way we were all taught and we all, follow it of the watch and wait. But the question would be, well, so many people are diagnosed with MGUS. The chances of MGUS is 1% over the age of 50. It increases significantly more as we get older. You don't want to treat all those patients because many of them will never develop myeloma. So we need to understand better who will develop myeloma and who will not, and define the patient who will progress in the next 2 years, in the next 3 or 4 years, and they're young and healthy. Why wait for them, and actually why don't we treat them early? Potentially we may cure them because they're still in very early disease and all of the changes have not happened yet, so we can actually get all those bad cells early on. And maybe if we actually screen patients correctly in the future, and I'm thinking 5-10 years from now, can we define everyone and can we prevent myeloma? Think of it as a preventable disease. Just like measles, we took care of it because of vaccines, although not anymore in California, but
yeah.
we will do it
and
right.
That would be wonderful.
Right. So the whole idea that we're doing right now with that prevention of progression is, one, can we screen patients and identify who progress or not? And do it in molecular ways, doing sequencing studies, doing actual molecular new next-generation technology. And two, can we define smoldering myeloma patients who can actually benefit from treatment? So we developed clinical trials for high-risk smoldering patients with clinical agents that are well-tolerated, that are known to work very well in myeloma, and we're testing them right now in patients with smoldering disease to see if we can actually achieve a good remission in them. So maybe I'll stop here and see if you have questions for me. Okay.
Well, at ASH, I was lucky enough to be at your presentation on making the microenvironment inhospitable for tumor growth. And what you're saying is, getting it and finding it in its early stage but then in that particular incident, it sounded like you're attempting to, I'll say, salt the ground of tumor soil and preventing it from blooming. And this sounds like a possibility for cure. Could you please explain this in a way that this audience will understand? Can this be used for early and late stage disease, or for high and low risk disease?
Yeah, so if you look at the mutations that we have in myeloma, if you do any of the cancer cells and pull them out, we know that there are specific mutations in those patients or cytogenetic abnormalities, which we all know. And if we look carefully at patients with MGUS, we find that many of those mutations are already there, which means the seeds, the bad cancer cells, may already have acquired the bad mutations. Yet some of them will never progress to myeloma. They're sort of stuck in there, and they will never grow and proliferate. While other patients, those same mutations and same cells will go on and develop myeloma very fast. So we're asking a question, well, maybe the soil around the seeds is the one that allows you to have progression to myeloma. And in some patients, it is non-permissive. It does not allow progression. So we're asking the questions of, are we born with certain susceptibility genes, or do we change something in our own bone marrow that makes us more susceptible to develop myeloma if we have this tiny mutation or in some of the cancer cells? While in some others, maybe your immune system will protect you and will not allow MGUS to progress to myeloma. And if we can use that to our advantage, we can develop drugs not only to kill the cancer cells, but also to protect you. There are so many new drugs now for the immune system. They're called the checkpoint inhibitors. One of them just got approved for lung cancer. And these are drugs that allow your immune system to go and target cancer cells. So in this case, we can think that in MGUS, if you have a good immune system and you will never progress, that's good. If you have a bad immune system and that will allow progression, we can give you a drug that enhances the immune system and prevents this progression.
Do you combine the drugs then as well?
You could. It depends. If we can personalize therapy, we could potentially even use drugs alone in early stages. One antibody may be enough to enhance the immune system, or we may need a couple of things, one to kill the cancer cells and another one to enhance the immune system. So it depends on the stage and it depends on the person, and hopefully we will have personalized therapy where we actually profile patients, understand what's going on, and then give them the specific treatment.
Okay. One thing that people have asked me, and actually Dr. Roy at Mayo Clinic here in Jacksonville once said to me, I was talking about one of the drugs that had been used in the mouse model, and now you have done this on mouse models with that microenvironment making it inhospitable for tumor growth, and I think these mice were actually cured. But is the mouse model what he had told me anyway is that if people were mice, they'd all be cured, And his point being is that we're a tad bit. What works in mice doesn't necessarily work in people. So as a result, but I understand that they're doing work on these mice models or mouse models that better reflect what will happen in the human being. And as a result, you have more repeatability. Is that true?
Yeah, so it depends on what you're using the mouse models to ask. So you're right. The human body is very complicated and much more complicated than a mouse model. And that's why we cannot predict what will happen in patients. We need to do the clinical trials with patients. However, you can ask specific questions in mouse models, and you can define how something will work in mouse models before you take it to patients so that you have a good understanding of the mechanism of action, of the potential problems that can happen before you take it into clinical trials.
Okay, well, thank you very much. The American Cancer Society provides data on survival by stage of the disease. Stage 1 at 62 months, stage 2 at 44 months, stage 3 at 29 months. And these are older numbers, I think. I think we're doing better than that. But does this prove that early treatment is more effective, or more an example of late diagnosis, or a combination of the both?
You mean like early treatment will give us like a lead bias of that we just change the numbers by treating early?
Yeah, stage 1. Yeah, right now, stage 1. I assume it's an earlier diagnosis, or maybe it's not. It's just, what they say is stage 1. You have 62 months. You live. At stage 2, it's 44 months. At stage 3. And this could be the proof that, if you get it early, like in a stage 1 phase, or DCIS, if it were breast cancer, that, early treatment means a longer life. Or does it mean that this is just an example of, a lot of people get diagnosed late, and at that point, you're at stage 3, and it's really a late diagnosis that this information is providing.
No,
or maybe
I think
it's just a bad question.
Yeah, the international staging system was used for patients who already have active symptomatic disease. So when it was developed, and I was at Mayo Clinic at that time when Dr. Phil Gripe developed the international staging system, which is what you're talking about, stage 1, 2, and 3.
Yes.
It was for patients who already have symptoms, who already have what we call the CRAB criteria, the high calcium, the anemia, the lesions in the bone. And we asked the question, well, within a group of patients who already have myeloma, which ones will have a really aggressive myeloma, and that's why it doesn't respond well to treatment, and that's why they have a worse survival, versus patients who have a very slow-growing myeloma that looks a little bit like MGUS and smoldering, very slow-growing, and it responds well to treatment. And within those groups of patients, it's the biology of myeloma. It's the type of genes that change. It's the type of lots of things that change within myeloma that can help you differentiate someone who will have worse prognosis or not. That's already after you have symptoms of myeloma. But the same applies for early MGUS and early smoldering disease. We have some classification that tells us this one will have a high risk of progression, so we call them high-risk smoldering disease, or intermediate risk or low risk.
Okay, so basically what you're doing, it's well before any one of these stages that your philosophy is to nip it in the bud before it ever gets to stage 1 or stage 3.
Yes, correct. And actually there was a study that showed a huge difference in survival of patients. So this was done by the Spanish group last year, and it was presented in the New England Journal of Medicine. And what they did is they took patients who have smoldering myeloma, which is before you get into stage 1 and 2 and 3. And they asked the question, should we treat them with the pill drug Revlimid or lenalidomide and dexamethasone, or should we do nothing, the watch and wait? And they found a big difference in the progression-free survival and overall survival of patients who were treated. That's the first trial that shows us that if we treat early, we can make a big difference in survival.
Fantastic. When Dr. Morgan was on this program not too long ago, and he felt the future of myeloma will be early diagnosis, safe treatments, chemoprevention strategies, regular screening for paraprotein, and early intervention. What do you see the future of myeloma care?
Yeah, absolutely. I agree with him. I think the one thing that I would love to see really is, can we prevent myeloma by detecting it correctly and treating it early for the right patients? And again, you can think of it that the best time to treat a cancer is at the early times, before it has changed so much, before your immune system has changed, before all of the effects have occurred. If you can detect it at an earlier precursor condition or pre-cancer condition, you can prevent the disease. And it would be beautiful that 10, 20 years from now we say there is no more myeloma because we're detecting it early and we're preventing it or curing it early. And that, I think, could make a huge difference for all of us.
And that's one of the reasons I found your presentation and this whole philosophy of treating it early and kind of salting the soil as being a cure for the disease. So, yeah.
We're hoping so. So we haven't proven it yet, and that's why we do need everyone to be part of it. I think the most interesting thing in patients with myeloma and smoldering and MGUS is they are very active participants. They want to be part of the effort, and they want to help do it. And that's the fun part, that we can all work together to understand what causes progression and how to prevent it.
Finding it early leads to a question, and that question is to treat early, you have to have a way to find it early. And right now, I understand that with 25% of the patients, with a time from first symptoms to diagnosis of close to a year, how do we get better at getting an early diagnosis? Finding this out so that we can treat it early.
Yeah, great question. So right now, we do not screen patients for the monoclonal protein, for the M spike. Yet we know that every single patient who is diagnosed with myeloma today must have had an earlier stage of MGUS or smoldering for multiple years without ever being diagnosed. So you're right. If we want to really prevent the disease, we have to start a screening study. And you can think the screening studies for cancer, so mammograms for breast cancer, prostate, the PSA levels, colonoscopy for colon cancer. We do a lot of screening studies to prevent 1 in 1,000 or 1 even in 10,000 cases of cancer to happen. Yet we have probably one of the best tools, a blood test, to screen for patients with MGUS and potentially diagnose them early, and we do not do that routinely. So for us to implement a screening study for MGUS, we need to prove that indeed it will save lives if you detect it early, and that's a big, huge study that we're thinking of, how to develop it, how to screen patients, what's the message we give to the patients if they're diagnosed with MGUS. So there is a lot of work that we're thinking of to indeed ask the question, should we develop a screening study for patients with myeloma?